Dear colleagues, I will continue the different groups of brain tumors and their practical approach on imaging basis. Group number 5 is peripherally located or cortically based lesions. Most of these have been discussed in the previous groups, but I will re-summarize them again and add some tumors to these. You remember ganglioma, pleomorphic astrocytoma, xanthoastrocytoma, the group of oligos, glioblastoma multiforme, it can come peripheral like this. Diffuse or low-grade astrocytoma, it is can be peripherally located, and astroblastoma. And of course, parenchymal metastasis can be added here, and we will discuss parenchymal metastasis in the coming few minutes. You remember astroblastoma, the very characteristic feature of it is the bubbly appearance of the solid nodule. And now we will add some of the tumors to the cortically based group. This emperioplastic neuroepithelial tumor, which simply we call DNET. Some people call it DNET without E, and previously called mixed glioma. But this is the most famous nerve, DNET, this emperioplastic neuroepithelial tumor. It is a benign focal intracortical mass superimposed on a background of dysplasia, of cortical dysplasia. Usually we see them in children and young adults, typically before the age of 20. The temporal lobe, often the amygdala or the hippocampus, are the most common sites. The parietal cortex, caudate nucleus, septum pellucidum are frequent sites. Intracortical mass, because of that it is benign and long-standing, it may cause scalloping of the inner taple of the skull and usually points toward the ventricle. As you see, this tumor is characterized by an appearance which is called bubbly appearance. You remember bubbly lesions? We have mentioned them in two tumors before, astroblastoma and central neurocytoma. Yes, the presence of bubbly appearance. It is well circumscribed, wedge-shaped bubbly cortical mass with minimal or no mass effect because it is more or less a benign lesion. In the T1, it appears pseudocystic, multinodular bubbly mass, and the same in T2, but it is hypointense in T1 and hyperintense in T2. And of course, in CT, it is hypodense. It calcifies in about 30% of cases. Uncommon to see hemorrhage in this tumor. Usually, this tumor doesn't enhance or shows faint nodular patchy enhancement. This is important. No enhancement or just faint patchy or nodular enhancement. Benign, so that lacks surrounding edema, and it is a benign, it lacks restricted diffusion. These are the different patterns. Bubbly appearance, okay, bubbly appearance in CT hypodense. I wanted to tell you that when we say that we have a peripheral lesion or cortically based lesion, put in mind that some deep structures like these gyri and this area of gyri are also cortical, like this one. And of course, we can see some nodular enhancement in 20% of cases. Another important sign that I always see or almost always see in cases of DNETs, what is called flare bright rim sign. In flare imaging, you know, if the cysts are CSF in intensity, they will be suppressed, but the periphery of the lesion is hyper intense in flare what is called bright flare REM sign. It can help you a lot. And as you see, in spite the lesion is large, its mass effect is almost absent or minimal. Some rare tumors that are cortically based, angiocentric glioma, okay? Remember this name, angiocentric glioma, because we will see another tumor called angiocentric lymphoma, okay? These are rare superficial low-growing brain tumors, typically presenting in young patients with intractable epilepsy. They were first introduced in the WHO classification in 2007, and they are classified as grade 1 W tumors. Angiocentric glioma are usually cortical or subcortical, typically well-delineated supratentorial tumors that tend to expand the affected gyrus. They exhibit a propensity to spread horizontally in the subbile plane and deeply along the vessels. On CT, typically it appears as an expansile non-enhancing cortical tumor, T1 hypointense, and it may show this hyper-intense T1 REM. Okay, remember this, hyper-intense T1 REM, similar to the flare bright REM in Dennett, okay, but here in T1. In T2, it is hyper-intense with extension toward the ventricles along the vessels, which have may have a cystic appearing mass in some cases. As you see, lesion like this, expansile lesion in CT, T1, and T2. Usually we don't see enhancement, no enhancement. It may have this weird appearance. Look for this. Very weird appearance, but it is typical if you see it, okay, in T2, because it has some tiny cysts inside, and usually we don't see enhancement. These are just enhancing vessels. Sometimes we can see extensions along the vessels toward the ventricles, because these are the planes of the medullary veins, and sometimes we can see T1 hyperintensities surrounding them and tiny cysts inside. Okay, it is a rare tumor, and I haven't seen in my practice such tumor until now. Again, it may show this bizarre shaped appearance, okay, T1 hyperintensity REM surrounding it, okay, or it may show this variegated appearance in its core. Just remember the shape of this tumor. Group number 6, some tumors which are peripheral masses with or without skull or meningeal invasions. Okay, we are speaking about lesions mostly originating from the meninges in this group, but of course they will include some lesions of the brain that may infiltrate the overlying meninges or the skull. Number 1, granulocytic sarcoma or chloroma or extramedullary leukemic tumors. These are solid tumors of myeloblasts, myelocytes, and promyelocytes occurring in patients with myeloproliferative disorders. We can see it in patients usually who are in the second decade. The same patient may show extramedullary hematopoiesis when they give similar appearance. The location is variable, but usually it affects the dura and less commonly the parenchyma. So these are the leukemic infiltrates in patients with leukemia. Let us see how it can present. Mostly as dural-based lesions, okay? All of these are dural-based lesions. If you have the history that the patient is leukemic, you should think that these are leukemic infiltrates. The other thing, which is very important, leukemic patients may present with hemorrhagic lesions in the brain, okay, due to depletion of the platelets or something like this. But the leukemic infiltrates also can be either hemorrhagic or initially hyperdense in CT like this. So you should give contrast and do MRI to see if these lesions are enhancing or not, because a lot of time these lesions are enhancing and represent leukemic infiltrates, not only just hemorrhage due to impaired hematostatic process in these patients. This is a very important example. Look for this. Hyperdense lesions along the meninges. Some people may call this subdural hemorrhage, but actually this is leukemic infiltrates. More than this, these tiny hyper intense T2 foci in the white matter, you will call them white matter disease. But if you inject contrast and see enhancement in these lesions, these are leukemic infiltrates. Another example here, hemorrhagic lesion. Actually, it is a leukemic infiltrate with some hemorrhage. If you give contrast or do MRI with contrast, you will see enhancement. Bland hemorrhage or hemorrhage, parenchymal hemorrhage shouldn't enhance. So isodense or hyperdense lesions to the brain may present with or mimic hematomas. Okay, take care that we can see skull base and paranasal sinus involvement. Look for this patient, okay, as if we have subdural hemorrhage here, okay, but there is subtle isodense lesions along the meninges. After contrast administration, what we see? These are meningeal infiltrates, complicated by some sort of subdural hemorrhage, or it is part of the leukemic infiltrate itself. So it is mandatory in these patients to give contrast. Another category of these lesions, something called extramedullary hematopoiesis. What is meant by extramedullary hematopoiesis? Patients with chronic anemias, such as thalassemia or others, the hemopoietic tissue can form outside or herniate from the hemopoietic organs like the bone marrow or the spleen and so on to make extramedullary masses. We can see this in the brain, nearby the calvarium or along the meninges. It represents compensatory formation of blood elements due to decreased medullary hematopoiesis. They present as homogeneous masses, but usually we have the history that the patient is chronic anemia. Usually we see it in the brain, in the epidural, dural matter, brain substance itself, skull, and sinuses. Let us see. This is very characteristic appearance, which is called hair on end with widening of the diploic space in a patient with thalassemia. look for the expansion of the diploic space in addition to enlargement of all the bones, including the mandible and so on. Okay, this is here on end due to chronic anemia. We see, in addition to the other signs of anemia, extramedullary hematopoiesis. For example, these are initially hyperdense lesions along the falx cerebri, hypointense in T2 because of the high cellularity, as I've told you, and it markedly enhances after contrast administration. The same patient may show other signs of extramedullary hematopoiesis as enlargement of the diploic spaces, obliterating the sinuses in this condition. Okay, how to confirm that these lesions are extramedullary hematopoiesis? We go to nuclear medicine because they actively uptake the technetium sulfur colloid, or if you do RBCs labeled technetium, they will show activity in these lesions. But we diagnose them indirectly by the presence of other signs of chronic hemolytic anemia. Another example, as you see, as if we have dural masses like this, okay, and the patient shows that he has signs of chronic anemia and hemosiderin deposition, widening of the diploic space, hemosiderin deposition, very low signal here, and on sulfur colloid, as I've told you, technetium, there is uptake of the radioactive material by these tissues. This was a patient with osteopetrosis, okay, where there is replacement of the marrow spaces by the abnormal bone, which indirectly causes failure of formation of the blood elements by this marrow, and expansion occurs additionally due to the anemia, and extramedullary hematopoiesis may be accompanied. Rarely, as a case report, it can be seen intraventricular. This is a case report of extramedullary hematopoiesis mass involving the trigone of the lateral ventricle, and as I have told you, other signs of chronic anemia is present here, widening of the diploic space and low signal. This was a case of thalassemia. Meningioma. Meningioma is very common. We see it a lot, usually in the middle age. The most liked position is supratentorial, and according to its location, it has its name. For example, parafalcine, outer convexity, sphenoid ridge, CP angle, petroclival, and so on. The other rare sites of extracranial meningioma formation are the paranasal sinuses, nasal cavity, parotid, skin, and calvarium. Okay. To remember meningioma, it is usually slightly hyperdense on CT. It may show calcification. On T1, it is more or less slightly hypointense or isointense to the cortex. In T2, it is usually isointense to the cortex or slightly hyperintense. It presents as extraaxial lesion, and of course you know how to differentiate extra from intraaxial lesion. Extraaxial, it means it is originating from the coverings of the brain, not from the parenchyma of the brain. And as you see here, there is a CSF cleft between the lesion and the brain and buckling of the nearby gyri. And of course, as you see, there is tissues displaced or compressed in between the extraaxial lesion and the ventricle. If the lesion is originating from the parenchyma, usually it infiltrates these tissues and the distance between the ventricle and the mass become reduced. Calcification can present as any pattern: rim, diffuse, globular, nodular, sunburst, sand-like. Usually we don't see hemorrhage, but it can occur in a small percentage of cases. Okay. Sometimes it may contain fat, which is a rare type called lipoplastic subtype. It shows intense homogeneous enhancement with what is called dural tail, which is non-specific as I have told you before. What is meant by dural tail? Thickening and irritation of the nearby meninges. It appears away from the main lesion on the surface of the pleura. We can see edema in the surrounding brain, but usually we don't, okay? But in some cases we can see vasogenic edema surrounding the lesion within the brain parenchyma. Again, as you see, this is the dural tail. After we have given contours, this is the dural tail. Okay? According to the location of the meningioma, it has its name. For example, this is a petroclival meningioma with extension into the cerebellopontine angle. This is a cerebellopontine angle. This is outer convexity meningioma. In MRS, we can see elevated levels of alanine at short. Okay. Again, regarding the name, this is outer convexity, CP angle, petroclival or anteroclinoid meningioma. This is the one I have told you, intraventricular meningioma, but this is rare. Okay, this is anterocranial fossa meningioma. An important finding that we can see with meningiomas, what is called is hyperostosis of the underlying bone. Okay, we see it in CT as hyperostosis. We see it in MRI and T2 as low signal T1 and T2. But there is a variant of meningioma called M-plaque or sessile thickened enhancing dura. We see it as a sheet of enhancing tissues, not globular lesion, but sheet-like lesion. This M-plaque meningioma usually infiltrate the underlying bone, causing hyperostosis and even intraosseous component of the meningioma. How we can tell that? If we give contours and see enhancement inside the bone. Sometimes these meningioma in plaque infiltrate the bone and having extra calvarial soft tissue component elevating the overlying scalp. Okay, so this entity is called M-plaque meningioma. A very common slide in your exam and in your practice is this pattern of M-plaque meningioma. It is seen along the sphenoid ridge, having intracranial thin rim of tissues, hyperostosis of the sphenoid ridge, and intraorbital component causing proptosis at the same side. So this is very characteristic M-plaque meningioma. Sometimes you can see enhancing tissues in the infratemporal fossa in the lower slides than these. Again, this is what is called M-plaque meningioma. Again, regarding the location, this is a parafalcine meningioma, CB angle meningioma. This is a clival meningioma or retroclival meningioma. Okay, retroclival meningioma, supracellular meningioma. Okay, supracellular meningioma, in this one, petroclival or cavernous sinus. When it comes to involve the region of this region, which is called planum sphenoidal meningioma, sometimes it goes more anteriorly into the olfactory groove here, and we call it olfactory groove meningioma, such as this one, and this is a retroclival meningioma. Meningioma can be multiple, and if you see multiple meningioma, you should think of neurofibromatosis type 2 and look for the other stigmata, including multiple schwannomas along the cranial nerves. Okay, this is intraventricular meningioma in case of NF2. Sometimes meningiomas may be accompanied by cysts. These can be either interrupt CSF as if they are forming secondary arachnoid cyst, or the meningioma itself has tumoral cysts, and there are some types of meningioma which contains this cyst called cystic variant of meningioma. The common meningioma is considered grade 1 WHO regarding benignity. But we have some meningiomas with atypical pattern, considered grade 2, and sometimes they are malignant from the start and considered grade 3 meningiomas by the WHO classification. But we see it in older age. We see it in earlier age compared to the common meningioma, about 10 years. If we see in the 40s, we will see this in the 30s. They present as dural-based lesion, locally invasive, with areas of necrosis and marked brain edema, usually anywhere along the neuroaxis. It behaves in a malignant way. How we can tell that it is behaving as a malignant way? It can infiltrate the overlying bone. It can infiltrate the brain itself. It is surrounded by vasogenic edema. So if you see malignant behavior of the lesion without hyperostosis, you should think of meningioma. The diffusion weighted imaging in atypical meningioma is much more restricted compared to the common ones. The common meningioma actually shows restricted diffusion, but the atypical one, due to high cellularity, is more restricted. Another tumor that occurs in the meninges is called hemangiopericytoma. And previously it was called angioplastic meningioma, but this is not correct because it is a sarcoma related to the pericytes of the capillaries, not from the meningothelial cells. Most commonly it occurs in the 4th to the 6th decade, but it can occur in all ages. Usually it is supratentorial in the occipital region. It typically infiltrates the falx, cerebri, tentorium, or dural sinuses. Rare reports of skull base, cranial nerve, and intraventricular involvement is present. It appears as if it is a meningioma, okay? Extraaxial, enhancing lesion, as if it is atypical meningioma. But actually, we see it in old age, and it shows aggressive behavior from the start. It means that it is infiltrating the overlying bone, infiltrating the brain, showing a lot of signal voids due to high vascularity, and it can also occur in the pericellular region. How can we differentiate? Number one, hemangiopericytoma don't show calcification like meningioma, so we will not see calcification. Number two, no hyperostosis of the related bone. On the other hand, it causes lytic lesions involving the overlying bone. As I've told you, it simulates aggressive meningioma or atypical meningioma or malignant meningioma, so it is wise in these reports to mention that it could be hemangiopericytoma or atypical meningioma, and let biopsy confirm the diagnosis. These are the locations of hemangiopericytoma, and as you see, it may mimic meningioma regarding its location, its signal, and so on. This simulates olfactory groove meningioma, and this one represents the skull base meningioma. But the clue in our hand is the lack of calcification and hyperostosis. In addition, it can show aggressive pattern of infiltration of the overlying bone and brain. Gliosarcoma, this is a rare tumor. It is seen in the 6th and 7th decade, usually affect the cerebral hemisphere. Its size is large, usually from 3 to 8 centimeters. It is an infiltrating mass which have a discrete portion, okay? Let us see. Usually the matrix is heterogeneous, simulating glioblastoma multiforme, hypo to iso CT, T1 hypo to iso, T2 undeflared hyper. We can see a lot of cysts due to necrosis, no calcification, we can see hemorrhage. It is heterogeneous, with or without dural involvement. The edema is marked, and it has dual supply from the external carotid artery and internal carotid artery. The key is a peripheral mass invading the meninges and may not be differentiated from glioblastoma multiforme. Actually, it is more or less similar to glioblastoma multiforme in its necrotic pattern of enhancement, but it is much more rare compared to glioblastoma multiforme. Glioblastoma multiforme itself, if it is peripherally located like this, it can infiltrate the meninges, and even it can infiltrate the calvarium with extracranial portion. In this condition, it is very difficult to tell. We will tell that we have an aggressive tumor infiltrating A, B, C, and so on. The differential diagnosis includes glioblastoma multiforme, number 2, gliosarcoma like this, but this is very rare, aggressive meningioma or hemangiopericytoma, and don't forget the simulator general, which is metastasis and lymphoma. Sometimes we have benign non-meningothelial tumors, what in the group which is called mesenchymal origin of tumors, such as chondroma, osteochondroma, osteoma. Okay, these tumors can originate from either the skull itself or from the meninges itself, considered as benign non-meningothelial tumor. If you see a characteristic feature similar to that you see in musculoskeletal system, you can tell its name. This is an example of osteoma. Okay, again, osteoma. Okay, this is an example of chondroma. It shows chondroid matrix with calcification like this. The counterpart of these lesions is the malignant. You can see angiosarcoma, chondrosarcoma, osteosarcoma, and so on. All of these are very aggressive, and sometimes you cannot differentiate. Okay, but if you see characteristic features of new bone formation, such as in osteosarcoma, you can tell that it's osteosarcoma. Let us see. Okay, these are aggressive mesenchymal tumors. Actually, you cannot differentiate them from malignant or atypical meningioma, and in this condition you should put in mind in your report that it could be an aggressive mesenchymal tumor. Okay, look for this. It shows new bone formation. This is a case of osteosarcoma of the skull, and this is a case of angiosarcoma of the skull. This is a very characteristic appearance that you should remember. If you have a peripheral lesion involving the calvarium and meninges, especially nearby the sutures or nearby the orbit in a child, put in mind that it could be representative of a metastatic neuroblastoma. And this is a very common scenario. Patient comes with lesions like this, and you diagnose metastatic neuroblastoma, and the patient goes to do ultrasound abdomen to find the mass, or CT chest to find a neuroblastoma primary lesion along the normal course of the nerves in which neuroblastoma originate, either in the chest, abdomen, or in the pelvis. Okay, let's see. This is very characteristic. You see enhancing lesions along the orbit, okay, having intracranial, intraorbital component, and a very characteristic appearance in the presence of some type of periosteal reaction similar to that seen in anemia called hair on end. You see spicules upon hair on end periosteal reaction. These tumors, like this area, likes the areas of the sutures. Look, this is along the sagittal suture, and this along the coronal suture, and it likes also the skull base, the mandibles, and the sinuses. Very characteristic appearance of this metastasis. If you see it, you will not mistake it. So consider if you see masses like this and a child with the specific hair on end periosteal reaction like this and like this, you should think to go to do ultrasound for the abdomen to detect a neuroblastoma lesion. Okay? Now, the group number 7, multiple lesions. This is the most common parenchymal metastasis. The parenchymal metastasis can present by all shapes, all locations, all colors, and actually it is the simulator general that you can put in the differential diagnosis list of many of the lesions. Okay, can present as hyper-enhancing nodules that usually loves the area of corticomedullary junction. It can also present as a solitary lesion with cystic changes and hemorrhage simulating glioblastoma multiforme. It can be surrounded by extensive vasogenic edema. Okay? Again, very tiny lesions like this, which we usually call them lacunes in elderly. But if you inject contrast and see that these tiny lesions are enhancing, put in mind it is metastasis. In addition, classically speaking, metastasis should be surrounded by extensive vasogenic edema compared to the size of the lesion, but it can present without vasogenic edema as in this condition. It can, like this, enhancing, it can present as ring enhancing lesions, tiny nodules, or ring enhancing lesions. Sometimes they are hemorrhagic, especially from breast and renal. They present as hemorrhagic lesions or hemorrhagic metastasis. It can involve the cortex, like this, not just the white matter. Nodule, solitary nodule involving the cortex, and it is enhancing. It can be surrounded by extensive edema, as I've told you, or no edema at all, like this. It can present as leptomeningeal thickening and enhancement. Okay, you remember the CSF seedling metastasis. Okay, but it can present as the pattern of metastasis from extracranial tumor. This a patient with cancer breast presented by leptomeningeal enhancement and pachymeningeal enhancement. Even in the spine, these are metastatic lesions. And unfortunately, it can present as a meningioma-like lesion. So, it is wise, if a patient with a known malignancy, such as cancer breast or something, and you see a meningioma-like lesion, don't be so confident to tell that it is a meningioma. Put in mind, it could represent a dural metastatic lesion. Okay? And in many times it occurs, you report it as a meningioma, but it is a metastasis. What I do in this condition, I report that it is mostly a meningioma, but considering the patient history of cancer breast, for example, metastasis cannot be excluded. Metastasis also can occur in a very atypical example. It can affect the ependyma or the choroid plexus. Okay? It can infiltrate the ependyma. And you remember this appearance? Subependymal lesion? Yes, we can see it in lymphoma and glioblastoma multiforme, and this is the third entity, metastasis. Okay? It can affect the pineal region. It can affect the cella, especially the stalk or the pituitary gland itself. Okay? It can affect cranial nerves as a part of leptomeningeal spread. Okay? And it can be seen intraocular. So if you are examining a patient with metastatic disease, put in mind to look to the eye globes. Many times you will find a lesion inside the eye globe along the choroid, and this will represent metastasis. Another very weird type of metastasis, which is called collision tumor. What is meant by collision tumor is metastasis, for example, on a pre-existing meningioma. So this is a meningioma, and on top of it, there is a metastasis. He is so unlucky. Okay, this is what is meant by collision tumor. A recently described tumor in WHO 2016 classification, something called diffuse leptomeningeal glioneural tumor, which previously is called disseminated oligodendroglial-like leptomeningeal tumor of childhood. It is rare and only recently described. It simulates leptomeningeal deposits. These tumors are most common encountered in children and adolescents, with a vast majority of reported cases less than 18 years old. It simulates as if you are dealing with leptomeningeal deposits or seedling deposits, masses and enhancing tissues along the leptomeninges of the spine, within the fecal sac, along the leptomeningeal surface of the brainstem, hypothalamus, pineal region, and intraventricular along the cranial nerves. Actually, if I see this, I would call it leptomeningeal metastasis. But put in mind, there is a tumor called diffuse glioneural tumor of childhood, which cannot be differentiated easily from extensive leptomeningeal metastatic disease. Of course, this is the differential diagnosis: tuberculous meningitis and leptomeningeal carcinomatosis, and this is much more common. Okay, but this tumor, which is diffuse glioneural tumor, is diffuse leptomeningeal glioneural tumor, is much more rare and recently described in the WHO classification. You remember intravascular or angiocentric glioma? This is the counterpart with lymphoma, angiocentric lymphoma, which is intravascular malignant lymphomatosis or malignant angioendotheliomatosis, angiotropic large cell lymphoma. It is a rare malignancy characterized by intravascular proliferation of lymphoid tissue with predilection for CNS and skin. It is a form of non-Hodgkin lymphoma. It presents as multifocal abnormal T2 hyperintensities in the deep white matter, cortex, and basal ganglia with enhancement. Usually we see it in the 5th through the 7th decade. Location is mostly supratentorial in the periventricular and deep white matter. May involve the basal ganglia. This is the pattern: lymphomatous tissue along the vessels. Okay, we can see it as nodules like this. Okay, punctate enhancement or linear enhancement, simulating vasculitis as if the vessel is inflamed, but it shows enhancing tissues and restricted diffusion. Okay, it shows restricted diffusion, and on angiographic studies it may mimic vasculitis. Put in mind that lymphoma in the body outside the CNS may send metastasis to the brain. Actually, when it is metastatic, you remember we have spoken about the primary CNS lymphoma, and this occurs initially in the brain. But metastatic intracranial lymphomas are metastasizing from outside brain lymphoma, and usually it likes the region of the meninges and bone, and may have nodular lesions like this involving the brain. It simulates any metastatic disease, but the primary is known to be lymphoma elsewhere in the body, and it behaves like lymphoma, restricted diffusion, initially hyperdense, simulating as if it is hemorrhage, with enhancement, of course, after contrast administration. Group number 8, cerebellar tumors. We have spoken a lot about a lot of these cerebellar tumors. You remember ependymoma, pilocytic astrocytoma, hemangioblastomas, okay, medulloblastomas. And this is the differential diagnosis of the lesions, okay, involving the cerebellum in childhood and in adult. We will add here a peculiar tumor called Lermue-de-Cloux disease. It is a benign hypertrophy of the cerebellum, sometimes considered as neurocystic blastomas, hamartoma of the cerebellum, a lot of names, but this is the most famous one, Lermue-de-Cloux disease. We see it in adults, but rarely seen in children. The location is the cerebellum, for course, and has a very characteristic pattern, which is the striated or laminated pattern like this. You find a lesion that it is hyperintense in T2, hypointense in T1, but the very characteristic appearance is the presence of this parallel striations. Okay, it rarely enhances, and it is considered as a sort of hamartoma, and it lacks surrounding edema. So the characteristic appearance, which is the striated appearance on MRI. These are the different appearances of Lermue-de-Cloux disease, and as you see, this striated pattern is very characteristic that you can diagnose this as Lermue-de-Cloux disease. A rare type of cerebellar astrocytoma containing fat called cerebellar liponeurocytoma. It is a cerebellar lesion containing fat. How we can know that it is fat? In CT it is hypoattenuating, in T1 it is hyper, in T2 it is hyper, and if you have a fat suppression sequence, you will see drop of signal of these lesions. It is a rare one. We can see it in from 24 to 77 years old, and the top differential diagnosis is medulloblastima with lipized cell, teratoma, anaplastic oligodendroglioma, ependymoma, and so on, if you see some fat. But this is a specific entity called cerebellar liponeurocytoma. Okay, the clue is the presence of fat. Presence of fat. And this is a fat suppression sequence. There is drop of signal of the lesion. I would like to thank you very much. I have tried to make some sort of approach. Of course, there are a lot of names, a lot of types, and as I've told you, the main rule of you as a radiologist is to tell that it is a neoplastic lesion, its relation, its location, its characteristic features, and trying by using your knowledge to narrow the differential diagnosis to a narrow list. And some of the tumors have very characteristic appearance, you can spot them, but in many cases it is wise that you can write a differential diagnosis, wise like differential diagnosis list, and you can raise some and make others less possible, and don't be astonished that you write some diagnosis that the pathology is not matching with, because there is a lot of similarity between certain tumors, but it is not a great problem, because your rule is to guide the surgeon to the important data regarding the relation, infiltrations, and so on. I would like to thank you very much, and we will meet in the next lecture about the anatomy of the spine and the radiological techniques used to image it.